ECG module part 2. In this video, we'll discuss about the basic QRS complex and the continuations in the part 1. So QRS complex, so as on its name, it has a Q wave, R wave and S wave. This is a normal lead to QRS complex. So it has various waves that goes up and down the baseline. These waves are identified as follows: this Q wave, R wave and S wave. So if additional waves are present, you can mention it as R dash or S dash. These designations may be added for additional waves if present. So for example, in case of an RBBB, right bundle branch block, there could be an RS R dash pattern. So this is an R, the S and R. So this is the positive. So any negative deflection from the baseline after an initial positive deflection is called an S wave, and any negative deflection before an R wave is called a Q wave. So this is basic nomenclature that is used. Regardless of the size of the reflection, capital and small letters are used empirically mainly for convenience. Although generally capital letters designate large waves and small letters designate small wave. So in most cases, we use an R, small r, in case when you want to describe this small wave, then and a capital R for a larger wave, and an S wave in between. So this is an RS R dash pattern, kind of an RBBP. So similarly, if there is a wave like this, then it could be an RS R dash pattern. So this is a more common pattern in RBBP. So next, coming to the Q wave. What is the Q wave? Q wave is defined as the first wave of QRS complex below the baseline. So for example, this is the baseline. Any deflection below the baseline is called the Q wave. So by definition, this is what it is: the first negative deflection from the baseline is called the Q wave. So if only a deep Q wave is present, that is without any R wave, the QRS complex is defined as a QS complex. So yeah. So for example, in MI, in later stage of MI, where there is an evolved MI, complete MI, when there is a transmural infarction that had happened already, then this is the baseline, you can expect a Q wave, and probably a continues with a T wave or maybe a T inversion also. So in these cases, this is called a Q wave. So when the Q wave is more than two small boxes, or when it is larger than the positive deflection, it is considered to be a pathological Q wave, which is seen in old myocardial infarction, predominantly a transmural myocardial infarction. So this is often called the QS complex, because the S wave, even if it is present or not, it will be buried into this large Q wave. So this is called as the QS complex. The R wave is the first positive deflection in the QRS complex. So if only an R wave is present, that is no Q or S wave, the QRS complex is defined as an R wave. So that is a positive deflection should be present, that is called as the R wave. If there is a second positive deflection, it is called the R dash, second R wave. So any positive deflection is called the R wave, and S wave will come next. S wave, this is the negative deflection after a R wave. This is called the S wave. So only you name it. These are nomenclature, basic nomenclatures that you need to understand. So R dash or R prime, we call this R prime in few cases, or in some cases there will be an R dash or R prime. So these are the second wave. The next positive, we define it as next positive wave after S wave. This is the definition, by definition. And S dash or S prime, this is the next negative wave or deflection after the R dash wave. So this is called the S dash pattern. So rarely there is also patterns that can be seen: R double dash, S double dash. These are the second waves, additional waves that are needed to describe the QRS complex. Double prime can be used for the next positive wave, or S double prime for the next negative wave. These are rarely used, and you see such waves. Okay, so now the QRS complex, how is it defined? So regardless of the number of waves present or not, a tall R wave without a Q or wave, S wave is still defined as a QRS complex. So it is just a complex identified as a QRS complex. Regardless of the number of waves, you don't need to have a definite Q wave, you don't need to have a definite S wave. Even if you present of just a tall R wave, it is considered to be a QRS complex. These are the basic definitions that you must need to know before we dive deep into the ECGs. So there are few criteria. There are standardization of ECG. So usually, when this is a big ECG slide and you have a rhythm strip here, near the rhythm strip there will be a standardization. This, when you see in your ECG, this is called standardization of an ECG. Usually this is 10 mm volt, that is 2 large boxes. So based on this, the other lead's electrical activity is measured. So if the standardization is somewhat low, for example, if you keep only one small box, the QRS complex obtained will be like this. It is just very small. Whereas if you keep normally at two large boxes, normal standardized ECG, then in this case there will be a normal QRS complex. In few cases, when you have a very low voltage ECG where the QRS complex is very small, in that cases you can request for a double standardized ECG, that is 20 millivolt standardization. In that case, you will be able to see the clear Q, R, and S patterns when you are not able to see. These are the cases when double standardization is used. So there are few areas where we can actually find the low voltage complexes. So what cases have a low voltage tracings where you need to request for a double standardized ECG? In standard limb leads usually have a QRS complex less than 5 mm, mainly R wave. This is normal. Whereas in chest leads, a QRS less than 10 mm is considered low voltage. So here, if it is more than 5 mm, it is considered normal. Less than 5 mm is called low voltage. Whereas in chest leads, if the QRS complex is less than 10 mm, it's called low voltage complex. So this you need to know. So there are various causes for this low voltage tracing. So causes for low voltage tracing. These are incorrect standardization, first thing. If less than 10 mm, obesity. In obese patients, the electrical activity may not be conducted appropriately to the skin surface, so it may be a cause for this low voltage tracing. Chronic constrictive pericarditis. Again, there will be a fluid between or fibrotic tissue, so this can lead to low voltage tracing. Myxedema, hypothyroidism, which is very common cause for low voltage tracing. Emphysema. Again, the lungs are over distended. In that cases, there will be an air in between the lingular segment can override the heart surface, can lead to low voltage tracing. And hypothermia are last. So these are the common causes for low voltage tracings that we need to see. These are very commonly encountered in clinical practice. So you must always see for standardization. Then you have to ascertain whether the patient is obese or not. If there is a constrictive pericarditis, myxedema, then you have to do a serum TSH. In emphysema patients, you can have a smoker, chronic COPD patients. In all these cases, you check for hypothermia at last. So these are the common conditions where you can get a low voltage tracings. So basic conventions that we have in ECG, we often need to know this. So positive deflection is above the isoelectric line. These are conventions that we are commonly following in ECG. This you need to know. So depolarization towards the electrode leads to a positive. So here there is a positive electrode. Any vector towards the positive electrode is considered to be a positive wave in the ECG. So these are limb of the patient, upper limb, head, the right arm, like this. So any vector towards this direction will lead a positive deflection in the ECG, whereas any deflection away from the electrode will lead to a negative deflection in the ECG. This is the first convention that you need to know. So direction of vector determines the side of deflection. This is the first thing. Second, away from the electrode is negative. So again, next is sensitivity. Commonly used sensitivity is 10 mm equal to 1 millivolt. This is the commonly used conventions and methods. Paper speed. This is another commonly used convention. It is always 25 mm per second. The paper moves 25 mm per second. It is 2.5 centimeters per second. Each large square, very important, each large square is 0.2 second, which is equal to 200 millisecond, equal to 5 mm in ECG tracing. Again, small square equals to 0.04 second, equal to 40 millisecond, equal to 1 mm in ECG. This is a very important conventions that we follow in ECG. So there will be, this is one large box. It has 5 small boxes. So that each one is This is 1 mm, this is 5 mm, which is equal to 200 millisecond equal to 0.2 second equal to this 1 mm is equal to 40 millisecond equal to 0.04 second. These are very important conventions that you need to know. Then the normal standardizations. So this is the 6 normal standardization that we already seen, equal to 10 mm. Rhythm, which is the interval between two successive RR. We call rhythm equal to interval between two successive RR. What is called as an interval? Any interval, you can say PR interval. So PR interval is basically P wave to QRS complex. So this is called the PR interval. Any interval includes a wave plus this segment in between the wave. Whereas a segment do not include any wave. It is just a segment. So a PR segment is, this region is called a PR segment. This is called the PR interval. These are few nomenclatures and facts that you need to know. Hope you learned all the basic stuff in this module on this ECG. This is medicine beyond comparisons. So in the next module, we'll discuss about the formation of a P wave and characters of a normal P wave, abnormal P waves, and what is the QRS complex abnormalities. Then finally we'll go into the PR segment, QRS complex, and each one. So if you do like this video, like and subscribe. We'll meet you in another video in this ECG. Thank you for watching.